Hello and good morning. So now we are continuing our previous lecture. We were on page 138. Now we will be on page 139. So in the next lecture, but we are still on page 131. So USMLE Step 1 Microbiology 2021, page number 138. We are discussing about the Clostridium species. So when we have talked about the Clostridium tetani, then botulism and Pathogenesis. Now we will be talking about the one of the high yield question, that is the Clostridium difficile. Why it's become a high yield? Because this Clostridium difficile is an organism that is normally they are the part of your normal flora. They are present in your intestine, but they are not causing you any disease. When we use antibiotics like penicillin or say fluoroquinolone, clindamycin, then what happen after using of antibiotics? The patient normal flora get killed, and because of that, the small amount of flora, normal flora, that is of Clostridium that was present inside your stomach, in your intestine, get proliferated, get chance to get boom, and then develop lots of Clostridium difficile in the intestine, and then they cause the infection and develop the pseudomembranous colitis that leads to the severe diarrhea in a patient who is hospitalized, who has undergone antibiotic treatment. So this is a disease not occurring in the normal people. This is a disease occurring after antibiotic therapy, mainly pertains to clindamycin, penicillin and fluoroquinolone antibiotic. So this actually produce, after getting proliferated, this produce toxin, that is produce toxin A and B, which damage the enterocyte, that damage our enteric cell. Both toxin leads to the water diarrhea, pseudomembranous colitis. You can see over there in the picture, there is the clear, you can see the yellowish part, that is the pseudomembrane formed by this bacteria, this toxin bacteria, and then cause the severe diarrhea. It is often secondary to the antibiotic use, especially clindamycin, ampicillin, cephalosporin, fluoroquinolones, and associated with the proton pump inhibitor PPI. So this is very important actually. You have to understand why and when it's actually developed after secondary use of antibiotics. What are those antibiotics? Those are especially clindamycin, ampicillin, cephalosporin, fluoroquinolones, and if a patient is using proton pump inhibitor, that is PPI, maybe pantoprazole, lansoprazole, omeprazole, anything. So fulminant infection may develop, that is called toxic megacolon or ileus and shock. Patient can goes into the shock by toxic megacolon and ileus. So what are this difficile causing the diarrhea? Diagnosis by PCR or antigen detection of one or both toxin in the stool, and treatment is oral vancomycin or fidaxomicin. For recurrent cases, consider repeating prior regimen or fecal microbiota transplant. So treatment depends upon the oral vancomycin or fidaxomicin. For recurrent case, we can consider of repeated regimen or the fecal microbiota transplant. So there is a lot of option. I will go to you. So let's come about from the beginning. Actually, Clostridium difficile is a germ bacteria that causes severe diarrhea and colitis in an inflammation of the colons. It is estimated to cause almost 500,000 infection in the United States. If you see the diagnostic part, will go there. This is the bacteria. This is the ingestion of the Clostridium difficile spore. They get germinated. Once adherence to their mucosal colonize over there, after colonization they produce the toxin, that is TCDA and TCDB, and there will be sporulation as well. This will be due to the infection. There is an inflammation and they form the pseudomembrane over their colon that you have seen as a this pseudomembrane. That is the yellowish colored membrane over there. Now talking, when you have known the pathogenesis, you can see other thing as well, like normal healthy gut, you give antibiotic, this colonize the Clostridium difficile, Clostridium difficile get increased, number of flora get killed. Now they develop this pseudomembranous colitis, and if antibiotic therapy is again given, the spore may remain and this recurrent may occur. Recurrence, there is always a chance of recurrence due to the spore. You can see after 24-hour exposure, cell of the colon lining are normal. After 30-hour exposure, Clostridium difficile toxin has started to damage the cell, triggering inflammation and fluid buildup. 36-hour exposure, inflamed cell burst and die. Clostridium difficile spores leave the colon via diarrhea and wait for the next episode. So you can see the changes what the Clostridium difficile is causing us. You can even see over here actually. So there are some The picture is not clear, but you can see the bacteria are getting colonized and then they form the pseudomembrane. The problem is that how to diagnose it. That is important. So diagnosis, there are the thing like we can do this. There are two different things. We are talking about not bacteria. Bacteria is the normal plant of your flora. So if you go and culture it, it might be not sensitive because people may not have the Clostridium difficile and may diarrhea may develop, may grow in culture. So that may not be. The most specific is toxin. If you find the toxin, it means the bacteria is dividing. If the bacteria is dividing, it means that this thing is over there and active infection is there, and that is actually leads to the confirmed diagnostic. So what are the things that can be done? One is glutamate dehydrogenase that can be done by the CLIA, EIA. This is relatively high sensitive rapid, but not for confirmatory. For confirmatory, you have to detect the toxin. That is can be done by again by EIA, rapid and moderate specific, but it has low sensitivity. Okay, culture, it is high sensitivity because organism can be recovered in the normal as well as the infected person as well. Okay. So cell culture cytotoxic assay, high sensitivity, long term time around also this can be also done. Another is NAT, that is the nucleic acid amplification. That can be also done, but it is a sensitive. But the thing is that it can be expensive and also concerned with the detection of the colonization. So the best thing that can be detect for the infection is you can send glutamate dehydrogenase and plus toxin A and B. The most confirmatory is toxin only. Now coming to the treatment point of view, if you see over here, the Clostridium difficile colitis, it is the because of the antibiotic use, especially clindamycin, fluoroquinolones, we have already discussed about it. It has developed the crampy abdominal pain, foul-smelling diarrhea, and the diagnosis is stool difficile toxin assay, elevated WBC, positive stool glutamate, and lactoferrin. So the measure is toxin. The treatment will be the antibiotics. Again, it was a disease due to develop after antibiotics, due to antibiotics actually say, because antibiotic has killed the normal flora, helps the Clostridium difficile to proliferate, and now this has colonizing your colon and then causing the pseudomembrane and developing the diarrhea. But those antibiotics are not their treatment, they are the cause, which we have discussed previously. Like we have talked about the clindamycin, we have talked about the fluoroquinolones, we have talked about ampicillin, cephalosporin, fluoroquinolones, PPI, clindamycin. These were drugs that was responsible. But when you talk about the treatment, the initial treatment is metronidazole, the oral metronidazole, even IV can be given. But nowadays they have said you can directly go to the oral, per oral vancomycin. Okay, so the treatment option left is per oral metronidazole or per oral vancomycin or per oral fidaxomicin. This vancomycin are available in the IV form for the treatment of gram-positive bacteria, but that is not used over here. That you have to be clear. That IV form is for killing gram-positive bacteria, but for killing Clostridium difficile, mainly Staph aureus infection we are talking about. But killing that MRSA-induced Staph aureus, we usually give vancomycin. But here we are giving vancomycin not in the IV form, in the oral form, and that oral form will go into the intestine and then kill your Clostridium difficile bacteria bug. So per oral vancomycin, per oral metronidazole, or per oral fidaxomicin. So these are the treatment options. Okay, let's again revise it and close our topic. Clostridium difficile causing the pseudomembranous colitis. You can see the yellow scalar. It produces the toxin A and B, which damage our intestinal cell and form the leads to the watery diarrhea due to and form pseudomembranous colitis. It can be even diagnosed with your endoscopy. It is often used due to a secondary to antibiotics use that we have know. Its complication may lead to the toxin megacolon, ileus, and shock. Talking about their diagnosis, we can diagnose by PCR or antigen detection of one or more toxin. Toxin will be helpful for detection. The treatment option are, again we know this is the oral vancomycin or fidaxomicin. For now, metronidazole has now comes to a lot of resistance. Although in initial days, metronidazole was one of the treatment of choice, but now they have been shifted to the oral vancomycin or fidaxomicin. For recurrent case, if the case is recurrent, then we may consider of the fecal transplant. We can get a normal person fecal and then transplant into the patient. That helps into the recovering of the patient. This is a very important because there are 500,000 people infected in the USA by this infection, and it is this by spore, that is spore forming organism that get transferred from one to one another person to the spore, which is not killed by your like alcohol or any antiseptics. You have to wash your hand, only then the spore are going to be killed. So since this is the hospital acquired in a hospital setting, you can see a lot of infection, and they are actually important point of view, and that makes it high yield for the USMLE and any other medical entrance exams all over the world. So we need to know the clear concept about it. Thank you.